Good afternoon. Welcome to our monthly webinar. Today we are joined by Stevie Perks, and I'll introduce him a little bit later to learn all about audits. My name is Ray Thomas. I am the Tropical Australian Academic Research Lead for, no, I'm not. I am the Research Lead for the Tropical Australian Academic Health Centre. Sorry, totally muffed that. A little bit about TARC, if you do not know about us first. I beg your pardon. Before we start, I'd like to pay my respects to the traditional custodians of the land on which we all gather today. For those of us in Townsville, like myself, it's the Walgara and Bindles people, and I pay my respects to the elders past and present. So now a little bit about TARC. So we are a research translation centre. We're accredited by the NH and MRC. We do a number of functions in northern Queensland. Our remit is to help with research training, building research capability and capacity, and we do that through things like this, webinars and our training courses, things like research translations training and demystifying research training. We have statistical consultancies and analysis packages in our platform called SEBS, where we work with people on their statistical analyses requests. We also work with people on study design and support and how we do that. So when people come to us asking about protocols and how to write things like that, we support them in that process. And we also give out money. So we have grant rounds throughout the year where we award local clinician researchers and local researchers in small seed funding and clinician fellowships. And this year we're launching a new round for a research translation round later in the year. Now, you're all interested at the bottom of this here. That's our website. All the information that you see on today's show and the webinar today will be uploaded onto the website and onto our YouTube channel when we're finished. So just a bit of housekeeping for today. As you've all done, please just mute your microphones while Stevie's speaking. We're going to have Q&A at the end, if that's okay with you, Stevie. It's usually fine to get the presenter to talk about what they need to do. Write down your questions, right? Because you should have a lot of questions for Stevie. I've never done an audit before. I've been a researcher for a long time, but I haven't actually done what's called an audit before. So I'm going to have oodles of questions, I reckon, for Stevie. But in the Q&A section, you can either raise your hand, and get called upon. You could write your question in the chat and I can monitor that for you. In the Q&A section, we would really like to see your faces, if you don't mind. It makes it much more enjoyable for us as presenters to see who we're speaking to. So if you have the ability to turn on your camera, that would be brilliant. And so today's presenter is Stevie. And Stevie has over 20 years experience working at the Townsville University Hospital, and he's spent quite a long time of that as the pharmacist in clinical education role, where he was also the quality improvement and research lead. Just recently, he's been fortunate enough, and rather Ori has been fortunate enough, where he has joined the Office of Research of Innovation in Queensland Health as a Research Navigator. So Stevie, I'm going to unshare my screen so that you can have your share. And over to you, mate. Thank you for today.
So tell me, is that working or are you seeing the wrong one? You're seeing the wrong one.
I'm seeing the wrong one. Yep.
Let me try and flip that around then. Sorry. It does it again.
Yeah, it does do that kind of stuff.
How do you do? There's a thing up here, isn't there? Display settings, swap presenters. There we go.
There you go. Well done.
That's it. Cool.
All right.
Bear with me. So yeah, thank you very much for inviting me along today. What I am, I guess, targeting to do is a bit of a intro, I guess, to audits with regards to clinician researchers trying to get involved in them. It's a tricky area to get started into because probably, as you see, as I present along the way, one of the biggest competing issues with regards to auditing something in your area is your clinical work. So if you've got clinical workloads and time is of issue, which is literally everybody I've ever interacted with, it's a time management issue. We need to make sure that when we're doing the audits that they are of value to us, that we're getting something from it. so that, you know, it's not just wasted time. And I would probably say that what I call, go into it in a moment, going the mud mapping phase of planning it out at the beginning is the bit that can be the difference between an audit actually finishing or not, let alone having good information from it, because a lot of, I would say, a large amount of audits that get started don't actually even get finished because we didn't plan them out in the right way, with the right people involved. And then once we got into the crux of it, when this is actually not feasible, or we don't have the capacity or the time, or the stuff we're collecting is too hard to do, or things like that. So these earlier stages is what makes sure that it all maps out a bit neater. So what I'll go through today is basically sort of two parts. One is what I call the mud mapping part of a audit, ensuring that you have the right components to it all to make sure that A, you can complete it, and B, when you do complete it, there's something that you're getting out of it, some value. And then if we have time at the end, I'll go through a very brief example journey of, you know, how you can use audits to either set up something else, whether it be a secondary audit or a change in practice or an innovation that you can then audit a second time after that to see how that's working. So it's sort of a way that you can see that you don't necessarily have to do sponsored clinical trials, randomized clinical trials to make a difference. You can do some amazing innovation at the coalface with audits, and then practice changes and audits and things like that. And I've certainly found that sometimes the audit and QI pathway can be far more impactful in changing patient care, because it's literally led by usually frontline coalface clinicians that they know, hey, this is a problem, I see it every day, let's get some information about it. Good, we've got robust information, let's make some decisions about that. Great, let's make a change. So it's sort of the audit process at the beginning is the foundation for setting up other possible options for changes of care, and that can be quite rapid, the changes. So with regard to the mud mapping, what it does is it makes sure that what your idea that you're looking at is appropriate for yourself, the team that you're working with, the unit you're working within, the time capacity, the time frames that you've got. It takes into consider all of those components to make sure that you can get this over the line, and also that when you do get to the end of it, you haven't expelled a whole bunch of time commitment to end up with a result that's not translatable into the next step. And it may be, you know, and when I say translatable, it could be value in a sense that we've set up another audit, or we've set up a change in practice, or we've just had a positive confirmation of our current practices. So we want to make sure that it's set up in a robust way where the data or the conclusions that we get out of it stand up on their own. So now, when I talk about value, and this is something that gets probably hyper focused, is the translatable outcomes. When we say what's the value you're going to get out of an audit, most people think, well, I'm going to find something that's going to change practice, which is one part of the possible value that you could get out of an audit. I mentioned before about the positive confirmations from audits. You know, if we have an audit that goes, hey, you know what, we're actually doing something great, that's really good to have done that audit, because that stops a new manager, executive, or someone coming along going, you know what, we should shake this up and change that. And you go, no, actually, we do this really well. I've shown that we do it really well. Can we leave that as it is? Let's look at changing stuff elsewhere. So you can have translatable outcomes that leave things as the same, which sounds odd, but you know, that it's useful information, even though they go, oh, it didn't show anything different or wild. No, it showed that you're doing something good. So the outcomes of the data is what I guess I'm getting at there, is the translatable outcomes, whether you're making a change, whether you're setting up the next audit or not, but it's the conclusions that you come up to. So that's the piece of work that I'm sort of referring to there. Now, the other two parts that I want to talk about is bits that get overlooked when I'm walking somebody through doing an audit, and it's the skills that you will learn along the way to be able to efficiently perform an audit alongside your complex workload. You know, you've got a clinical workload, you've got to figure out how to manage your time, what team you need, what buy-in and stakeholders and people that you need along the way to get the job over the line. And the skills that if you're translatable value of your audit might be on the lower side, but you are learning how to do this so that when you come across a more complex issue that you could get something very good out of, well, you're a bit more rehearsed at this and you'll be able to do this a lot better. Also, potentially you've built some partnerships or relationships along the way so that when you get to the innovation side of things, you've already built a bit of a network that's going to be able to achieve the next step of things. So I always think about it's about the piece of work, but it's also about the person that's doing it that we're getting value out of as well. It's not of value is an audit for the sake of audits. They drive me nuts, but you do see them every now and then because somebody has invented a KPI for the sake of a KPI. I hate the word KPIs, but there's you'll often get those things, and when you come across those, you go, but what's the purpose of the KPI? If you ever get rolled or dragged into one of those things, sometimes you just need to do one more step, which is let's break down the KPI. What was the intent of it so that you can actually collect something worthwhile rather than just a number that someone sends up to somebody else to say, I've got a number. Bit cynical of me Wednesday. Other things that are not of value is poorly designed audits. So it's quite heartbreaking to see people go and spend 6 months working on something and then they come up with a number, a few numbers, a few answers that don't actually answer what they were intending to begin with because they've collected the wrong data, or you're making assumptions beyond what the data can actually interpret, and it would have required only a tweak to the data collection tool here or there, and you could have something much more significantly more valuable. So not value to be poorly designed, and also poorly designed audits lead to people when they get onto the next stage or going into doing a study of their own, and they don't know how to write a protocol. They don't know how to write how I'm going to collect data, how I'm going to store data safely, how I'm going to analyze data, all of those kind of things. Then you sort of fall on your face a little bit when you have to write something a bit more robust when you're running your own study of something like that. So we don't want people learning bad habits. You want to be set up, whether you're doing an audit or a randomized control study, you want to be robust in the way that you plan your piece and the way that you execute it and evaluate it. So this is, and I can flick it to Ray if you want to share it around afterwards. I've got this, I call it my mud mapping sheet. It's like a 2-pager A4, and it has these 5 points. And this is what I mud map before I start writing a protocol, because I have a lot of people come to me when they've spent maybe 2 or 3 months of their 1 hour a week spare time scribbling stuff, and they've tried to half write a protocol out. And then I say, bring it back, let's brainstorm some things. And then by doing this, you could have saved yourself a heck of a lot of time, or refined it in a way that made it a bit more efficient to work on. So it boils down to refining your question, planning the data points you can get access to, and what you're going to be able to collect, whether what you're going to do with your statistics and evaluation, the stakeholders you may need to get involved to be able to execute on the project, and then always earlier on thinking about what would this look like? Is this a foundation audit to set up a secondary audit? Is this an audit that's going to set up a possible change if you get X as an answer or Y as an answer? Who would you need to be involved? So I'll work through these questions, and that's sort of what the crux of my mud mapping is. So when I talk about the writing down a clear question, this is probably one of the most important steps, is to actually understand what question you're actually asking, and then will that is that answerable and what we're going to get out of it. So when you write it down, do you need to redesign it slightly to create any translatable value? Now I'm going to use a couple of very, very simple examples to hopefully elaborate on that. So if I was to say, where am I going to there? This one here. So how many patients are charted opioids post-operatively without a max dose or sedation scores when they've just come out of theatres? So we're worried about, someone's on the wards has said, some of the nurses reported, we're seeing these patients getting narked all the time. Okay, so we've got this question here. Now, if I was to ask, at this point, I ask the person that's planning on doing the audit and say, what will you do with the answer to that question? What are you going to do with that? Like, what will that tell you, and who will you pitch that to make a change? So if I end up finding out that 40% of orders have a sedation score and 60% don't, and you take it to Dr. Smith, the head of surgical services group, and you go, what are you going to do about it? And what would she say? She might say, what does that mean for the patient, would be what I think she would probably say, because at the moment you've just got a number of how many people have something written on their medication order. What are you going to do about that? So sometimes it requires a little bit of refinement. So potentially what I'm more worried about is not necessarily just what's written on the paper, but potentially, well, how often do the nurses actually do the sedation scores? Is probably a value point as well. So how many patients are actually getting the scores checked at the point of post-op dosing or opioid dosing? Or potentially even more valuable than that is, well, what kind of outcomes are we actually having for the patient? How often are the patients actually deemed to be too sedated to receive post-operative opioids? And then potentially a back end of how many risk mans you've got of narked patients, which as a separate point isn't a great data source risk man, because it relies on staff input. So if the staff are busy, they just won't input it, and we won't know that we've got a high rate of narked patients. But this here, so you can see that a slight bit of changing the question around. So now my question might be something more like, what are the prescribing administration practices of opioids postoperatively with regards to sedation scores and max doses? And that would be the title. But what I've essentially done by using this point here, the first point, and then adding those two extra ones, is I've kind of almost started framing my objectives of what I'm going to get out of this, because each one of those things will tell me about essentially the supply chain to narking patients, right? How it's prescribed poorly or not, whether the nurses are doing sedation scores or not, and how often patients are narked. So a little bit of tweaking, and I've got something that's going to be so much more valuable to Dr. Smith when I say, hey, only 40% of our patients have the scores written, and of those 40% that have them written, we're finding that only about half of them actually getting sedation scores, and we have, of that half again, we have a fairly decent rate of not being able to give doses. So if we extend that out to the 60% of patients that aren't getting any even prescribed, we could be doing a lot of improvement in patient care by tidying up this whole section. Does that make sense, hopefully? So it's about redesigning potentially the question to have more relatable and usable information. So moving on to the second one is about the data that you would get to support answering your question. So when I think about the data sources, you're asking yourself, whereabouts are you going to find the answer to these questions, and what are you going to be able to do with these things? So the first question I ask is just for the process of getting access to the data sources. Is it a Queensland Health data? So is it owned by Queensland Health, or is it external to Queensland Health? Because there are pathways to make it easier and harder, and if you have any issues with that, you can talk with research, one of the research facilitators at the different HHSs, based on whether you need PHA applications, ethics applications, or if it can sit under Hospital Health Boards Act. There are different ways to access certain types of data if it's managed by Queensland Health. And then also asking yourself, is it data mining, or are you creating another data set yourself? So if it is something, and this is hugely of importance, especially for all the sites that have gone digital. So that's, I think, all of us except for Mount Isa, so Northwest at the moment, and Torres, haven't gone digital. But for the digital sites, or if you're pairing up with them, there are ways to do data mining access. Whereas if you are creating it yourself, like it's something that you need to do on the fly, and you need to check boxes or mark things based on patients incoming, that's going to have a huge impact on your ability to be able to actually execute on these audits as well. So, which brings me to the next point: is, can it be automated or manual? So if it's something that exists as a a data point that is already written consistently into IMR or something like that as an automated process, or it's already written in a dashboard, a ED dashboard, or Hibiscus, or in iPharmacy, or any one of those digital platforms, it may be able to be retrieved much more easier rather than having to manually go do it. So let's say, for instance, you wanted to capture a patient group that had COPD or something like that. You could go to your patient flow manager and look every day for the next month and see which patients had COPD written on the handover. That's quite manual and tedious. Or you could go to an ED dashboard and do a pull of that date to that date of admissions that had admission linking to COPD, and straight away there you go, you've got your patients in about 10 minutes of like flicking through an Excel sheet that you've pulled from an ED dashboard, as opposed to having someone that has to manually go and find all of these things. So anytime you can automate it is certainly much better, and also it'll have a huge impact on the people that you need to have involved in the time frame. And also with regards to the coding of the data, is it free text or I guess what I refer to as hard coded? So for instance, if you're using OzLab or something, or IMR with the data that's coming across, and EGFR renal functions, or certain bloods and pathology, that'll come across as a specific data tile. Whereas if you're looking for something that says, were they I'm trying to think of something that's not hard-coded. Let's say smoking was only documented in free text notes, their smoking status, or marijuana usage or something like that. And you have to go and pull all of your COPD patients and then go, now I need every one of their clinical notes, and I'm going to have to sift through the whole thing to find out whether they smoked marijuana or something like that. That's going to add a huge amount of time and for your ability to actually be able to finish this audit. So sometimes at that point as well, you need to ask yourself, what's the value that you're getting out of that specific data point? And this is where I call pruning data points off your audit. So are you going to get the value that you think, like, let's use the COPD example. What's the value that you're going to get out of finding out whether they smoke marijuana, or admission rates and time to antibiotic for some other study that you're doing? Is it of huge value, or is it something that I can cut a huge amount of workload off because I don't have to sift through 6,000 sheets of notes, and it doesn't truly affect the outcome that big? So sometimes you need to let go of a couple of, and I've had people that you tend to hold on to all the things that you really want to know, and you say, but what would you do with that information at the end? Is it that relevant that it would change significantly the outcome? And oftentimes it's not, so you can just cut those ones off, prune them off. The other part is when we're doing automated versus manual. If you're doing manual data collections, think about, is it something that it's simply a diagnosis or a word that you can easily find, or is it a pattern or something that can be interpretable? So if you've got two different people collecting the data and they can come up with different answers, that I refer to as an interpretable data point, which you don't want. You want something that is uninterpretable, so that it will always come back, you'll get consistent information. Otherwise, you get to the end and you're analyzing the data, is just it all falls apart because it's inconsistently recorded, I guess. So keep that in mind. I think I've actually mentioned this already. So is there a way to adjust your question to allow for automation of the data, like data collection? And can do you need to prune anything off? And then also, does your method of collection introduce any bias? So this one here is particularly to do with the team or the timing of the collection. So considering things such as, I'm going to do this audit, but I can only get a nursing student or a pharmacy student or something to collect it, and they are only available on a weekend. So now I know I'm collecting weekend data only instead of weekday data or something like that, which I know, that the care and the level of clinical work is different for weekends for weekdays, so that can throw your numbers off. Or let's say I was looking at, meropenem usage at my hospital during a certain period of time, and going, oh, we've got really high usage, but I happen to look at the wet season compared to the dry season. I know that we use antibiotics, those ones, more in different times. So you've got to have a think about how and when you're collecting it and who's collecting it, whether that's going to introduce any bias, because if you get to the point where you're trying to sell this idea to somebody to do the next thing, and that there's a chink in the armor, it can all fall over and go, well, it's not really usable because X, Y, Z, and you go, darn, I've just wasted that time. Moving on, so the third point that I had that in the mud mapping is the statistics point. So always making sure you mud map or think about this early on. So what kind of data are you going to be getting, and how you're going to be representing it. So, and you don't have to, when you're doing simple audits, sometimes you don't need to have high-end statistics involved. You might just be doing this to map out a theme of what you think you're seeing. It may be simple descriptive statistics of what's happening in your area. Also, you may be just simply comparing it to either a comparison group or a standard, or potentially like a statewide guideline or something like that. So breaking down how am I going to know if this is good or bad? Like, what's my threshold for good or bad? What am I comparing it to for good or bad? How am I going to describe that this was good, this was bad, or this was effective or not? So having a think about that, and oftentimes, if you're unsure, just talk to a statistician, and they may say, no, for something like this, it's quite simple. We'll just do some simple numbers and compare that to the standard, and that's as complex as it needs to be. Or they may say, actually, this is quite robust. Let's do this, and they may say they may do a look at the numbers and say, look, we want to see 60 people to make sure it's got enough power to tell this compared against a statewide standard or something like that. So, and I've certainly been involved in both ends of those ones, depending on how in depth or what kind of audit you're doing, I guess. So yeah, if you're not sure, talk to a statistician, and they're super helpful, and they can usually wrap their head around it pretty quickly. Now, the last 2 points, the stakeholders and translation, are very heavily linked. So some of the stuff I say here will be mentioned in the translation part. But when you're thinking about stakeholders, think about how you're getting the right people involved to make sure it's successful. So the first one is, who's going to be collecting the data? You may need to have partners to get this done. The more the merrier for working on audit, as long as you've got a consistent way of collecting the data. So if someone else is collecting it, you got to make sure you have a reliable process, so that you have consistent information. Inconsistent processes means unusable data, but also if you are using other people collecting the data, that certainly involves more asking for favors, and that's where it can get a bit trickier. And this leads into the next point: how long will it take? So, and does it need to be supported? Sometimes you might need to sit down and go through, well, if I'm collecting this and it takes me 8 minutes, time yourself with 3 or 4 or 5 patients to actually get, and I tell that to all of the students that I supervise now, because I do a few audits with honours students, that I want them to sit down and actually do 5 to 10 patients and give me a gauge of your time frame, so we have a realistic idea of how many data points you're going to get versus how much time you have, or vice versa. If you've only got a set amount of time, you can reverse engineer that to know how many data points you're going to get. If you have a set amount of data points you need to get, you can calculate how long that's going to take you. So realistic numbers about what it's going to take to get it done will stop you from the surprise, will save you from the surprises of getting started on an audit and then realizing, oh, this is way bigger than I thought it would be. That's it, I'm going to file it in the bottom drawer and it's never going to go anywhere. So once you get that information, you can figure out how much time I can commit to it a week, and over what period of time it's going to get achieved. And then you can go to the people such as team leaders, line managers, executive support, that kind of stuff, to figure out this is what I would require to get the job done, and this is the kind of information that you're going to get out of it if you let me do this, that kind of stuff. So having it all planned out and having all the right people involved is critical to making sure it gets over the ground, over the line. Now, other things is to consider doing it without hindering anyone else's work. So I mentioned a bit earlier on, if it's something where you require potentially, like every time someone is seen with they got admitted and their BGLs were a specific range or something like that, and go, can the nurses flag that and write that down in a book or something like that? If there's anything extra that's not in the standard of care for an audit, you're asking for trouble, because A, are you introducing a change to patient care? Probably not if you're just auditing, but B, you're likely to not get the full patient group or the full data set that you're chasing, because people are going to struggle. I just know that when you've got competing clinical interests, do they go and do the other job that they've got to do, or do they write out the thing that they have to for the person? So if you can minimize it down to not having extra tasks for anybody else within within the healthcare system, and a way to try and collect data without impeding the efficiency of anyone else, which is also why it's so good to to try and plan it as potentially like a retrospective data mining, so that you can get a data set that's there, and then you can attack it in half-hour blocks when you find a bit of time, and that certainly is rather than I have to be here this time this day to record that, and the nurses have to do this and the pharmacists have to do that. Those ones are the ones that fall over all the time if you require other people to do it. So now this stakeholders part, and this leads into a fair bit into translation, this part, is I ask myself at the beginning, before I get started and writing up a protocol, because there's nothing more, I don't know, if you send a 3/4 completed protocol to a few people that you want on board, and they're like, oh, but have I missed this? Are you forcing it on me? Rather than them being a part of it, you're less likely to get them on board. Whereas if you get them on board in the mud mapping phase, and then you can send them, hey, this is the protocol I'm going to start writing up, and you send them the blank copy so they're aware of it, and then you put their name on the beginning of it. That person is now one of your champions that's going to help lead get the audit to completion. But then if we want to create any change out of it, they're more likely to support that as well. So I always think about, if I got something interesting out of this, what would I do with that information? Who would be the champion for change? And then in a converse point to that, who might block this? If I find something interesting and someone goes, yeah, but we just don't do that because we're from North Queensland and we never change. And I've had that answer too many times, but in practice. But and you go, but why? And I've had projects where, personally, I've had ones where I've got all the way to the point of doing a really good audit, and I'm like, you know what, this would be great to change that piece there, and I didn't have one or two key people involved, and I was like, because they didn't need to be there for the audit, but man, I should have got them, because they're the ones that are going to help with the change, and it just completely boshes everything, and it basically it stops it in its tracks, because I didn't have the right people involved. And that's a learning point that I acquired along the way. But always think about who can drive it forward, and who is potentially likely to stop it in its tracks, and get them on board as champions, or as executive aerial support, potentially for different things as well. Yeah, so, and this is where, so the translation, I said, often has a huge overlap with the stakeholders, because they're the people that you are going to get involved. And if you break it down to the translation of not just the change, but I want to translate this to getting it completed as well. So firstly, who needs to approve any workload timing, looking into this project, me getting my half an hour a week, or someone else getting this time to do that, getting them on board. And then, as I said, the any of the champions or stakeholders that may be heavily involved in creating the change, get them on board earlier. But it sometimes takes a bit of conceptual thinking to be, well, what would I, at the end of this, what will I do? I know who I'm going to talk to about this. What would I think that they would do based on what I'm seeing in clinical practice? I'm sort of predicting what the data will tell me. You never know, but like, you work in this clinical area, so you often have a pretty good feeling about what you're going to find. And you go, if I find what I think I'm going to find, what would I do? What would that look like? Would that require, changing practice, recording something extra, that kind of thing? And sometimes, if you've only got a finite amount of time in your work day, which you do, you want to pick an audit that's going to lead towards something that has translatable changes that are achievable. And when I say achievable, I guess, to single out the easiest one, I mean not an increase in FTE, because that's something that just falls over every time. You're like, do you know what I found? That we need to do more stuff for our patients, so give me more stuff. That's it. That'll fall on deaf ears. So if you've got like 2 or 3 possible options of projects, and you've got one that isn't going to lead directly to just, I need more staff, I would pick those ones rather than the I need more staff ones, because you're more likely to get traction with outcomes from that. Yeah, if that makes sense. So this is my mud mapping sheet that I use for students and other staff, and I can flick that to Ray if you want to share it around. And it's just a scribble sheet. Sometimes you don't know the answers to different parts of this, and you just scribble it down, and then based on that, you refine your question a bit. You think about who I need involved, what's my team going to look like, that kind of stuff. And then once you have that information, you have sort of a mini framing stakeholders meeting to sort of get the thing up and going. And you say, now I'm going to drop it into an audit protocol. So now, see that blank names there is one of the most important things to getting stakeholders involved. If you've got 2 or 3 names already on that and you ask someone to be part of it, they just immediately, they're off half a step off, because they go, well, am I just added on because you just wanted me to, as a buddy system? Whereas if you say, hey, I'll be filling this in, you show them that, and then you basically from there, so much of this information will drop into there. What are my aims, objectives? What's my actual question? How am I going to be collecting the data? What's my outcomes? You've done a bit about data and sample sizes and things like that, or how you're going to analyze it. So much of this stuff in here will drop into there, but you've mud mapped it a bit, so it's going to be a bit more clearer to get the ball rolling. Rather than what I see people do is they jump straight into this and they start writing, and they go, I'm going to spend the first 3 weeks writing my background and introduction, and then I'm going to do this and that, and then they get to it and you talk to them and go, well, that's excellent what you're thinking of, but the data point that you're thinking about is not automated. It's not written in a hard-coded area, so you're going to have to manually find that. This is an enormous workload for the payoff, so it's likely not going to happen. And then they go, and they get really disheartened. So sometimes you need to mud map a couple of different ideas first before you dive straight into the pool with this. And you don't have to use this one, just use whatever audit protocols or that you would have at your sites. So that's my mud mapping process. Any questions about that, or do I want to just go on to I've got a example of an audits evolution that I have. Do you want me to continue on, or any questions for now? Or no? All right. Do you want me to go? Yeah, I'll just go along then.
People are very interested in your mud map, and I will send it round when you send it to me. Right. And I will also put in the chat in a minute the YouTube site where you can find the webinar when we're done.
Yeah, great, excellent. So this is, I just wanted to show you an example of how audits and I will say quite simple audits can lead to innovation and change in practice. And for me, I'm only showing you one side of the audit evolutions that from my side, the ones I was involved in, and then the innovation at the end. But there were several other people looking into this problem. We had a big problem with VT prophylaxis at our hospital. I had a resident pharmacist in maybe 2019, I think this started for me, looking at, she was working on the surgical floor going, man, they don't do really good for knees and hip prophylaxis. Okay, so we put together a piece to audit it. We had a really good standard to audit it against, and we were getting information. It was actually manually done because I think we had paper charts back then, so she had to collect the paper charts and retrieve them. So it was quite a bit of work for her to do, but she was doing it as basically a postgrad, so she had time to do that. And we had as I said, the statewide guideline as the base to compare it to. Now, don't look too heavily at the data in there. Essentially, what it came back as was that only 37% of our patients were actually prescribed VT prophylaxis in line with the statewide guideline, which we were like, oh, that's crazy. That's nowhere near what it should be. And the big thing from that, we found that aspirin comprised of nearly 60% of the patient cohort. And of that 60%, 4 out of 5 patients were deemed high risk based on the Charleston score, which is inbuilt within the statewide guidelines. So we had very poor rates of VT prescribing in that one specific area. Now, there was other actual clinical trials going on in the area at the time to determine whether aspirin should be used or not. So that was sort of sitting in the background, but it sort of led to the next stage, which is, well, is it just this group? Is it just the ortho guys, or are we doing it poorly across the whole hospital? So and as I mentioned, I was doing these ones from a pharmaceutical point of view, and there was other nurses doing similar audits from a mechanical prophylaxis reviews and things like that in other different areas. So the next one we worked on was audit 2, so it led to another one, and we said, why not look at the whole the rest of the building, so the acute medical wards. So we looked at a portion of surgical before. Let's look at the acute medical wards, and by this time we had IMR in place. So, excellent. This was sort of our first crack at understanding IMR data and what we can get out of it. And they had power plans, and the thing that we were trained when we first learnt it was, if you use the power plan, it's got all these supportive functions within the power plan. So it should help you lead towards a better prescribed VT prophylaxis. So let's look at the medical patients. Let's look at the power plan usage, but that's just a number. So what does that translate to if you're using the power plan compared to the statewide guidelines? So that's where I say that you have added that extra detail on. It's not just the usage of the power plan. Was it more accurate if you use the power plan? So that's how you've got a better answer. And essentially it worked out that use the power plan, 90% compliant with statewide guidelines. If you don't, it's 38%. So it's hugely, and that's highly significant. It showed us that using the power plan, more likely to get it right. And while we're in there, we were like, well, we've got this data, let's break it down a little more. And once we broke it down into specialty groups, it was a little bit, some of the groups were quite small, but impaired kidney function, 100% versus 18, significant difference. So we looked at the high risk groups, BMI greater than 30. It was not quite significant, but getting very close to it there. And then also the smaller weight people. So these are our 3 highest risk groups for VTE. For getting it wrong, I should say. And we found that it was significant nearly, and then significant in the bottom group there. So we had some really clear information that we're not doing it well in across the building in certain areas, and also that the high risk groups are certainly in trouble as well. So from that, we've got a bit more information. We also found that mechanical prophylaxis was not being done well in certain areas. We got a big group of people together from IT guys, nursing, executive, medical, pharmacy, all of us together to design a whole of hospital dashboard that pulls all the information from the VT Pro with regard to VT prophylaxis prescribing, including the power plan, including mechanical prescribing, including weight of the patient, because the weight is a key thing that will adjust the milligram, the dose that you're on. And the renal function, the most recent renal function was on it as well. So we could pull that at the point, and I can't show you a live version because it has patient details on it, but it's a live version, updates every 10 minutes, I think. And we can see the whole of the hospital. Like, we can click on it and break it. I should have, sorry, I realized I didn't change the slide. We can click on it and drill right down to teams that they're in, the wards that they're on, the actual patient, their weight. I can just screen it by weight and click on weight and then look at all the people that are over 140 kilos. So it was a very usable tool that met the needs of the nursing people that have been doing audits, the pharmacy people, the medical people. So all of these people that have been doing their separate audits, finding these deficits in the way that we were handling patients, sort of glued them all together and said, what's the product we want? We've got this dashboard. Now, the important part about we did a lot of work in I guess rolling out a change in practice. So that was a whole body of work separate to the audit as well. But we wanted to know that, well, how do we know this works? And this brings us back to, once again, almost the auditing phase. Like, what are the things that we're going to look at to determine, does this dashboard work? And the simplest one is the total rates of VT prophylaxis plans that were in place. So, but if I go back to my base principles and go, but what does that tell me? When I pitch that number to somebody, what are they going to do with that? At the end of the day, that's just a number. It's a number of how many power plans there are. Theoretically, it'll translate to better prescribed things and better care because of the other audits we've done. We know that it has the more power plans, using the power plans as better prescribing. But we haven't yet looked at any clinical outcomes. So like, what we wanted to make sure we had in there was using actual robust information that is very well recorded, which is our hack data, which all the hospitals are involved in. Your hospital-acquired complications with rates of DVTs and PEs over time to see if they have improved or not. And all hospitals are involved in that, and you essentially get a report back where, based on the acuity of your hospital and the patients that you see and how many you see, they can say you should have a rate of X, and this is your current rate. So we were significantly higher than our expected rate, which was terrible. I didn't write it there, but we also looked at bleeding rates as well, which they didn't change over time, because obviously we don't want to just go, hey, we solved all the DVTs and PEs, but everyone's bleeding out of their ears now, so don't want that. So essentially what we came up with, what we got based on this was our implementation phase, where we were sitting between 40 to 60% as our baseline. This is where I started collecting at 57. We steadily increased the rate of VT prophylaxis plans, and we now sit between 85 to 90% fairly consistently. So that was hugely valuable. And just as an amusing factor, you can see the little dip there. Does anyone want to wager a guess what that is for, because of being in February when the medical interns start their year? You can see a nice drop there, but anyway, we've overcome that and got back to normal. That's always usually that's the first question I get: what happened there? Well, that we got new stuff. So that, but once again, this here is just a purely from an audit point of view. That's a number that you can infer a few things and you can make a few assumptions about it, but you can't actually overstep and say I've done anything just based on that number. Whereas this one here, this was so that was going up till December 2023, which sits about around there, and you can see that we tracked down massively. This was the hack data, and we actually, on the next slide, we won a whole bunch of awards across, like, internationally and across Queensland and Australia, based on this. And I'll clarify, it's not because of this, it's because of this. And if you're trying to sell someone on creating a change or maintaining a change and putting time into keeping these kind of things, you need to think about, am I getting this from my audit, or am I getting this from my audit? What this page represents is the actual clinical outcomes. We had a hugely significant drop in DVTs and PEs at the same time as we were rolling this out. Which is excellent, and we didn't have any increase in bleeds or anything like that. So a massive increase, and it meant that we had the ability, yes, we'll keep this, we'll maintain that, because if we had have stopped and only recorded that and not realized we'll mold this together, it's far less impactful. So take home points, I guess, from me is the mud mapping is hugely important. So getting involved with that before you start writing up your protocol, getting the right people involved, designing your question a bit better, and making sure that the data that you're getting is going to be able to tell a story that can set up something else or change something, and that it's not an individual effort. The more people you have involved, the more likely you'll get this thing over the line. And sometimes you need to actually, and I tell people, go have three different. If you want to do something, have about three or four different ideas and mud map them out. And you might go, you know what, this is a great idea, but that's all manually pulling this from inpatient notes, and that's just simply unfeasible. That would take forever. Whereas this one here, we can talk with the data, a data lab, and get the data pulled, and I can just work through it in bits. Which I'll just quickly, while I'm on this page, I'll quickly plug that Townsville has an amazing data lab. So if you're from the Townsville area, we've got access to guys that can pull really accurate, good data sets from all of our IMR, and that is evolving across the state. So Cairns and Mackay are growing. They will be getting there. There are ways to get access to this, but they're not quite at the point that we are here. But certainly keep that in the back of your mind, because the long-term plan would be great, as if we can easily access across multiple sites. We can work together as a larger unit, and that's not trying to exclude anyone from the other areas that don't have it, because hopefully we'll all eventually have digital as well. But keep that in mind. If you want to know anything about that, you can link in with us or other people too. So that's my summation. Any thoughts or questions?
I have a question. Is that all right?
Yeah.
Hey, I'm Chrissy. I'm telehealth coordinator. We are looking at doing more of a audit from data and that sort of stuff for one part of implementing specialized equipment for video conferencing live within theatres. So we already do that from a Western corridor rural facility to a hub site, to Spoken Hub model. Now that we have this equipment, it makes it really accessible, easy, purpose-built, and we'll have an integrated system in the background. So some of that can be automated, of when we called, where we called from, which system to which system, that sort of stuff. So that sounds helpful from what you're saying. The question part of it, because one, the whole state is sort of wanting information from this, from a telehealth point of view, obviously, to see how is this sustainable, blah blah blah, that sort of stuff. And repeatable. The other part of it for our HHS is, now executive always want to know about the transfer of patients, how many are transferred, do we need to transfer that patient, that sort of stuff. For me, so I've got a bug. That is kind of, from a clinical point of view, null and void, because if the patient is at a rural site and they need extra care, they're going to be transferred, But the use of the equipment is really for access. It's access to services in a timely manner and that sort of stuff. So I was listening to you going, can I borrow your brain for like a day?
Well, reach out to me afterwards. Sounds amazing. I'd love to chat to you about this, but it sounds to me like, and this is another thing, I probably didn't mention this, but sometimes people think of audits in isolation, that it's an audit and that's the whole piece. Whereas many of the bits that I'm doing as audits, I think of it, I always have a bigger plan of where does this sit in the whole picture, right? So potentially, this is me just quickly brainstorming with you, I would have an audit piece based on the data points of how many people you see, and how many came in, and how many you either didn't transfer or did transfer. Those kind of metrics that'll tell a picture of the workload, the money that you need to commit to it, time frames, et cetera. Then I would probably say, but that doesn't actually give you, contextualize what you're trying to say to the team. So I would probably then look at picking out, and you can do this when you do write up a paper, you can pick out 4 exemplar patient scenarios or something like that, where you go, these are 4 examples where this patient here, because it's not, like you said, it's not about transferring, and I've sort of diverged away from audits at the moment, but it's not about the transferring at the moment. It's about the patient that possibly would have died. Like, find patients that this patient would not have got there, and we did X, Y, and Z, blah, blah, blah. And these are 4 examples of how that helped, because they're probably chasing a KPI that doesn't really exist for the value that you're creating. Does that make sense? But that's how I'd
Absolutely.
possibly
I agree
frame it,
with
something
that.
like that. But reach out to me and email me if you want to, and I'm
Well,
happy to
thanks,
catch
mate.
up. Yeah.
Any other
Anyone?
questions from the panel? Trina, you have a question. Trina.
Hi, thanks, Stevie, for that. My question is just more about observational audits. Is there any consideration with that? Because I've got a research project going on, and part of the data collection is going to be around an observational audit. We've just modified our own, like the HHS's clinical audit, so it's for clinical handover. So when you're talking about automating, you know, we have to observe clinical handover, nurse to nurse handover. Is there any considerations around, I mean, we've just kind of modified it, but to ensure that the data that we're collecting by observing the nurse to nurse handover, we're also going to confirm that information by looking through the patient's notes as well, whoever the data collector is. Is there any other considerations that you would say?
No, so that it's a tricky one because so are you going to be adding extra points that they need to, when they're doing handover, they're going to be having to add extra stuff to that, or is it just someone observing them do the handover and documenting it?
Yeah, so the research project is around like the quality of clinical handover, because we've
And then you'd
increased.
compare that.
Yeah, we've changed our shift patterns. So we've
Yep.
increased the time from 15 minutes to 30 minutes with a 10-hour night shift. So we're comparing two different wards, one's that's still on the 8-hour night shift, one's on the 10 hours, to see the quality in terms of, like, we obviously have our clinical handover procedure, like we've got the standards, communicating for safety standard. So there are, like, obviously the right way of giving handover. So the data collector will be just literally observing the interactions and the information that's actually provided, and then I guess looking at the patient's notes to ensure that the right information and adequate, sufficient information was provided.
Yeah. So I guess that sounds great, and you've got like a standard to compare it to of what should be required in the audit, in the handover. So you've got someone that's recording that. Where it could get a bit trickier, a bit grey, is what you're planning on doing with it with regards to, are you planning on publishing it, or you're planning on just using it to help set up a bit more of a look into it? Because if you are using different people to be recording it, it can get a bit tricky. You'd probably need to have a way to say that the people doing the auditing are consistent. You know, if you were trying to publish this, you would need to validate that me looking at the handover versus you looking at the handover, we're getting the same answer in that. And there are ways of approaching that. It just depends what you plan on doing. If it's all internal, you probably don't need it to be that robust. But if you're planning on publishing it, which I think you probably would, that sounds publishable. There'll be a way to get that inter-person auditing consistent, or validating that.
Ideally we want to have one person that is doing the data collection for that exact reason.
That would be
but funding is kind of like, we're at a bit of a at a bit of a point of, like, we have applied for grants and been unsuccessful, so it's like trying to work out then how do we get funding to employ someone to then do that particular job. So it may come down to the fact that we may just have to get staff on the ward to do it, which might be a mix of people, which is not ideal.
I mean, the other thing, it's a bit tricky if you start recording. It's too tricky. I was going to say, for an audit, you don't really want to be recording voices, but I have to have a think about it.
Thanks.
No worries.
We have 1 minute left. Any other burning questions for Stevie? Look, Stevie, I learnt a lot from the talk today. Thank you very much. I got some take homes. One of my biggest take homes, and I really like how you pulled out, it's like, you can come up with a number. What does it tell you, right? So what does it mean? And that is pivotal, right? You have to make sure that whatever you want to do, because your time is precious, that it is indeed valuable. And dovetailing on that, what it means afterwards is how does it translate? What's the translatable outcome? Not just what does it mean? What does that number, what does that thing mean? What are you going to do about it? And how do you preference that with your people? Who are the champions of change, which is a great phrase as well. So thank you very much, Stevie. I really learned a lot from that. In the chat, I put the TARC YouTube channel. Probably not this afternoon. As soon as it gives it to me, I'll do a bit of a trim and I'll pop it up there. You've also, in the chat, I've given you the research event calendar, which is usually populated with lots of events that are happening all over Northern Queensland from our various partners that you're always welcome to attend whenever you'd like to. So thank you very, very much, Stevie. That was really great. We are 2 o'clock. Is everybody fine? Everybody ready to get back to their day job now? Thanks, Stevie.
All good. All right. See you guys.
See you later.
Thank you. Bye.
Thanks. Bye.